You're listening to Fast Facts Perio Edition. And now, here's your host, Katrina Sanders.
Hello, and welcome to Fast Facts Perio Edition. Today, I am so excited for you all to meet my new friend and wonderful, amazing periodontist, Dr. William Levine. Dr. Levine, welcome to Fast Facts Perio Edition.
Hi, Katrina. It's actually an honor to be here. So thank you for inviting me.
You are so kind. I love this, and I'm so excited to share you with everybody here, my audience listening to Fast Facts Perio Edition. So for my audience, Dr. Levine is a practicing periodontist. He received his training here stateside and practiced in Manhattan before moving to Israel, where he's been practicing as a periodontist for the past 30 years in a large group perio, pros, and oral medicine practice. And so I love this because what we do on Fast Facts is we geek out about the newest content, funky research that's coming down that could, or rather should, change or transform the levels of care that we're providing to our patients. And I mean, provocative statement, sometimes it takes forever for some of this research or some of this content from, abroad to make its way stateside, right? Like we've got so many areas of red tape and things like that. But it really is incredible how innovative a lot of research is in some of the alternative medicine areas. So today we're going to be looking at some of that. Dr. Levine, let's share with our audience your fast fact for this episode.
Well, I think the first and most important fact that I'd like to share with you is the main driver behind periodontal disease is inflammation, not infection. And this is something that's been very well known for many years, but it's very hard for us to control infection. So in our field, we just keep killing bacteria, and we're not getting the full benefit that we can get from managing periodontal disease. So I basically was based on an aha moment one morning when I woke up and I'm getting dressed. I looked in the mirror and I'm saying to myself, too many patients, not just my practice, but all over. And if you look at all the studies that come out there, analyzing patient populations in private practices and in university settings, the data keeps repeating. 17 to 25% of our patients have refractory periodontitis.
This is refractory perio. So they've had periodontitis, they've received a diagnosis, they've received treatment, and
they're stable.
And they're stable. Okay.
Right.
Got it.
And now refractory periodontitis, either in one spot or in two spots with a significant amount of disease. And this data repeats itself. So accept the fact that the fun fact that it's consistent. There exists between 17 to 25% refractory periodontitis in well-treated, stabilized patients. That's an enormous amount of failure.
Okay.
And that means that we're doing something wrong.
That's huge. That's, I mean, 1 in 5, maybe 1 in 4 of our patients who have periodontitis are at risk for re-entering into a refractory state. Is that correct?
Absolutely.
That's crazy.
It's an enormous number. And it means that we may be fooling ourselves slightly to thinking we're in control of this disease, but in reality, we're not really. So that was my aha moment where I said to myself, okay, we're killing bacteria and we could do that fine. We can scale and root plane and debride pockets, that's fine. And we can do this on a consistent basis. But what are we missing in that puzzle of patient management that we have not yet provided? Well, let's just sort of take a deep dive into what's going on inside the tissue. When you have periodontal disease, what really happens? Our bodies function normally. So let's say, for example, there's a micro buildup of plaque in a certain area of your mouth, or generalized, it doesn't matter. The normal body reaction would be an inflammatory reaction. And that's fine, that's healthy. Just like you would in sports, if you overwork an area, it'll swell and it'll heal. But in periodontal disease, you see a flare-up, you see swollen gums, you see bleeding, you see all the things that you guys know how to treat and recognize, and us too. And the patient is managing that disease through that inflammation. That's called reactive inflammation, normal health. Now, what happens if that reactive inflammation does not resolve? what happens is then it begins to then develop a more dysregulated inflammation. In other words, if it didn't resolve, it means it's not functioning. And if it's not functioning, then it means something's wrong there. So what's happening is the inflammatory process is spinning its wheels, spewing out enormous amounts of cytokines and different toxic elements designed to control the infection. But in reality, it's not controlling the infection. It's rather driving down and destroying the periodontal attachment. And that's when you get periodontal disease. So periodontal disease occurs at that junction between a reactive inflammation to a dysregulated inflammation, or sometimes called chronic inflammation.
Sure.
Exactly.
So I was just going to say, so we're talking about the graduation from acute inflammation, and acute inflammation is really important, right? Acute inflammation is, it is reactionary. It can oftentimes cause pain. It's the body's means of saying, danger, danger. There is a local irritant in this area. There's a foreign invader. There's a foreign body. Something's going on. That response is a protective one. But then if we don't start thinking about the complexities of what happens inside of the periodontium, and we'll talk about that in a short minute, then we see that movement from acute inflammation into the chronic state. And that chronic state is where now the body has started to kind of shift some of those processes, higher levels of inflammatory cytokines. And we see that in other comorbid issues, right? Like cardiovascular disease and obesities and things like that. That's where that chronic inflammatory process, where the body's no longer in this, I'm not going to say fight or flight, but the body, when the first contact it has with these foreign invaders of biofilm components, the body's trying to get rid of it. And then as we move into that chronic state, the processes shift.
Exactly. And well said. And that's what's connecting periodontal disease actually to all the other diseases that it's associated with. Is it's an infection. It's true. There's a spewing of bacteria into the blood system, and that's been documented. But the bigger driver is you've elevated your inflammatory profile. So you'll see that's what happens, for example, in cardiac disease. The minute someone has an MI or myocardial infarct, they want to monitor that CRP. CRP is simply a bland general modulator or measurement of your body inflammatory profile. And so by having acute and active periodontal disease, if you've elevated your inflammatory profile, you are putting yourself at risk for all those diseases. But specifically, you're also at risk for greater periodontal disease, which is contributing to that as well. So we need to figure out how we manage that inflammatory process and minimize the switch between between reactive and dysregulated inflammation. So that was my aha moment, and that's why I came late to work that day, because it took me a while to stop thinking about it.
These are the things periodontists think about when they get ready in the morning.
So I sort of said to myself, okay, we need to develop something that will be easy to apply, that will address the inflammation, and I'll drill down into that point a little bit more, and that can be topically applied, because having a systemic drug that can manage inflammation and manage periodontal disease, A, it's a silly way to treat it because you can access it topically. B, there's been historical evidence of more than one drug that can do this, and yet people don't want to take medicine on a daily basis systemically to control periodontal disease. Just look at the collagenase inhibitors, and look at some of the anti-inflammatories that people use. People do not want to take those as a drug, and I don't blame them, because they have lots of side effects.
Sure.
So we wanted to find something that was pharmacologically active, and yet could control inflammation. Now, inflammation is not a single gene or process where you could turn on and off. It was referred to as a cascade because it really is like a cascade. It's many, many different cellular, vascular signaling, and connective tissue changes which are taking place, which if you just try to put your finger in the dike and hold one of those pieces closed, you're not going to get an effect. The body will work around it and continue the inflammatory process. But if you manage to multi-target the inflammation, then you could actually generate a therapeutically beneficial effect. So what we did, we looked into the world of botanicals, because There's a realm of active pharmacologic agents present in every botanical material. We just have to identify what they are, what concentration we need them. So we went into the plant world, which I had no experience with. I was completely naive, and it was a learning experience of many years of mistakes and many years of, oh, wow, that's great. But in the end, what we did is we took 3 plant materials after many years of research. One is Echinacea purpurea, which you're mostly familiar with, as an immune booster, but actually we use it for different processes. Another one is Sambucus nigra, which is actually not Sambucus like the drink
Right.
they have, but
That's what I thought of right away.
Yes, no, me too. It's an elderberry. Okay.
Oh, nice.
Yeah. So talk about wine another time.
There you go.
Yes.
Yeah.
Always a good topic.
That's right.
And the third one is something called Centella, which is Asiatica, which is actually known for its wound healing properties. And together, what we broke the plants apart. We put them into many disease models, into many different bioassays to understand which compounds are active against which processes, and what synergistic activities actually are there between the 2 processes. So we basically built a synergistic relationship of 3 materials at specific concentrations, and we actually generate a process from growth through harvest, through manufacturing, through the product in the bottle, to make sure that you will get a drug-like effect from a natural product every single time, because all the active agents have to be there in order for this to give you maximum benefit. So it's been a process that started off as, oh, how long would this take me? A few weeks?
And here you are.
About 20 years later, I'm still making it better on a regular basis. So that's how we approach this. We basically created a product. And if you think about what happens in periodontal disease, we have a microinfection, we have an inflammatory reaction, and then we have tissue destruction. And we needed to address each one of those. So we have the antibacterial level here is very, very potent. It comes from the natural materials. And what it does is it can kill bacteria just like every other antibacterial on contact, okay? But it also reduces inflammation. And it multi-targets the inflammatory process through a number of the critical cytokines that you've all heard of: NF-kappa B, IL-1, IL-11. They are all pro-inflammatory mediators that we can, and that's how we downregulate the cascade. Now, another fact that happens here, which intuitively you'll know, well, we all know that inflammation nourishes more bacteria. In fact, if the better word for plaque nowadays, although nobody uses it, it's called bacterial dysbiosis.
That's right.
And the reason for that is these bacteria survived your inflammatory attack. So it's, in a sense, the character of that bacteria, and the plaque is basically determined by its resistance to your inflammatory attack, because the rest of them were killed. So you've created that toxic mass of bacteria, and that's why it forms so oddly in the pocket, because it's what's resistant to your body, which is why it's so dangerous to us. So we needed to strengthen that body. We needed to reduce the inflammation, and it stops feeding the pathogenic bacteria. So you get a specific kill of the toxic bacteria because you're not feeding them anymore. So we're starving out the population. And then on the third level, and I think this is also critical, we actually cause an increase in collagen buildup. We have thicker epithelial layers, and we're able to generate, in a sense, a classic wound healing effect, which makes that tissue more robust. And there's recent data that came out that showed tissue that has more collagen, and it seems to also be more resistant to disease. Now, we all intuitively understand that, because anybody who works with tissue says, oh, that makes perfect sense. Nobody's actually shown that until very recently with data, but we didn't need data because we knew it was true. So we do all those things. Then what we basically do is, again, kill the bacteria, because that's important.
Yeah.
And it helps. And then what we want to do is we downregulate the inflammation, and then we also strengthen the tissue with the wound healing effect. Now, we use that in our practice on almost all our patients. Don't forget, it's a perio practice, not a general practice. Yeah. The only time we break our golden rule is when we have a patient who demonstrates or seems to be tending towards a higher caries rate. And then we need to add fluoride into the matrix. So either we'll add a fluoride rinse in as well, or we'll put them on fluoride trays or high fluoride toothpaste. But in general, our patients, anybody who has an implant, anybody who's had periodontal disease, anybody who has a tendency to recession, and we all know how hard it is to treat recession. This will actually slow down the process of recession and actually thicken the tissue at the border. So there are really miraculous things that can be done with a product that has such a pluripotential effect. And so I'm just excited. You better shut me up because I can keep going.
Well, I absolutely love this. I think it's so impactful for us to start changing the way that we actually look at the different modalities that we're using with our patients, that it's not just about what are we killing, but moreover, what is it that we're doing with our chosen medicament or whatever product that we're going to be prescribing to our patients? What is it that this product is doing to preserve symbiosis in the oral cavity? What is this product doing to continue to build resilience around this oral epithelium? Because we do recognize that, and it's so hard for us to picture a lot of times, but in a healthy periodontal situation, and I'll say this to you because you're a periodontist and you probably don't know what a healthy situation looks like anymore, but in a healthy situation, we do want to have a resilient cellular epithelium. We don't want it to be ulcerated. We want that thick mechanical barrier to be able to prevent the entrance of bacterial infiltrates and their byproducts into our bloodstream circulating through the body. We want to be able to protect how the body responds in a host response situation. Our immune system and the way the immune system shows up is absolutely critical inside of this. So I love this. This is part one. I want you all to stay tuned because next week we're going to unpack part two, where Dr. Levine and I are going to be looking together at some of the more common medicaments that have been used in historical surveys of periodontitis, and comparatively how utilizing something that has more on the natural botanical side has been able to render optimal benefits when compared with some of our medicaments. This has been another episode of Fast Facts Perio Edition with Katrina Sanders. Please feel free to reach me on Instagram at The Dental Wine Genist or on my website, www.katrinasanders.com. Cheers.